Welcome to Mammography Challenges. Today we're going to talk about transgender mammography for mammographers. There are a number of terms that are associated with transgender, and we realize there are a lot of common terms that are also associated with this subject. For purposes of clarity and simplicity, we will use the term transgender throughout this presentation. This is the Challenges in Mammography series, and today we're going to talk about transgender mammography. I'm Mark Struthers. Over the last decade, the number of transgender individuals seeking medical care has continued to increase. Like many, I have transgender friends and transgender family. The transgender population has historically been more vulnerable to health disparities and structural discrimination, leading to inadequate health care. Transgender women taking hormone therapy are at a higher risk for breast cancer than natal males, but lower risk compared to natal females. Cross-sex hormone therapy for male to female transition typically consists of two components: anti-androgens to reduce the testosterone levels, and exogenous estrogen to develop the desired secondary characteristics of a female. Although there is a modest increase in breast size for individuals following this hormone therapy, approximately 60 to 70% of the patients pursue surgical breast augmentation options as well. The standard surgical methods used in the United States utilize saline or silicone implants to augment breast size. However, some patients may have had injections of free substances such as free liquid silicone for the purposes of augmentation, although this practice is illegal in the United States. We'll begin by looking at breast cancer, and the fact is that most patients undergoing breast evaluations will not be diagnosed with breast cancer. However, symptoms of benign breast abnormalities are quite common and impact many more lives. Accurately diagnosing and explaining these non-cancerous conditions can alleviate much anxiety in addition to helping patients toward a correct treatment plan. There are many challenges associated with mammography for both men and women. We find for the mammographer one of the biggest challenges is for patients that have had body modifications, such as implants. There also may be challenges on patients that have had mastectomies, with scar tissue making it difficult to demonstrate the breast area. Whether it is a screening mammography or a symptomatic diagnostic examination, everything about a patient's experience in the mammography is heightened because of the fear of breast cancer. So mammographers must be able to not only do the technical job, but communicate very well with a sensitive population. Each patient they examine have the idea, will this be the day that I am told that I have breast cancer? And that's a worry. Mammography is considered one of the most challenging modalities technically within medical imaging. When performing the mammographic exam, the mammographer has a number of things to think about, from positioning and body habitus to breast composition and pliability, physical limitations or ailments of the patients, and as well as the patient's emotional state. That is why mammography is considered one of the most challenging of all the modalities. The radiologist relies on the mammographer not only for their scientific and technical skills and knowledge, but for their patient interaction and compassionate care, resulting in a good exam for the patient and diagnostic information for the radiologist. The mammographer must recognize patient conditions essential for successful completion of the exam. Aside from the performance of high-quality imaging, the most important service that a technologist can provide for their patient is effective communication. The mammographer must explain the examination to the patient and interact with the patient, communicating any information that they have that will be beneficial to the patient. Transgender individuals are increasingly referred for both screening and diagnostic breast imaging. It is important that the clinical equipment and environment is welcoming and the medical staff utilize accepted terminology and patients can designate their gender and personal history to ensure appropriate care. Hormone and surgical treatments used for transition by many transgender women and men may change the approach to imaging the breast. The mammographer must communicate with the patient to get a clear understanding of their history. Transgender people have a different gender identity than the sex they were born with. It is believed that 0.5% of the population is transgender. A transgender man is someone with a male gender identity, but a female sex assigned at their birth. A transgender woman is someone with a female gender identity, but they were born as a male. Sometimes the terms for the genders and the definitions are confusing. So let's review a few of the terms and their definitions. The first is gender identity. And this definition is that it arises from an individual's internal sense of being male or female or something else. The term I've been using over and over in this presentation is transgender. And that is an adjective to describe an individual whose gender does not align with that they were assigned at birth. As we just reviewed, a transgender woman is a person who has assigned male sex at birth but identifies strongly as a female. And a transgender man is a person who was assigned female sex at birth but identifies as a male. Transition is a term referring to steps taken to alter outward appearance to align with the person's gender identity. Gender reassignment differs from the term transition. Gender reassignment refers to steps taken to permanently alter one's phenotype and can be achieved by hormonal treatment and surgery. Cisgender or non-transgender is an adjective to describe a person whose gender and gender expression aligns with that was assigned to them at birth. Due to stigma and discrimination, transgender individuals have suffered from a lack of access to competent medical care. Given the growing desire among healthcare professionals to improve access for the transgender community, it is critical for those in the medical community to develop methods for delivering culturally sensitive care in a welcoming environment. Once the mammographer has acquired the appropriate history from the patient, the next step is to accurately document and communicate the relevant information to the radiologist. The increasing use of cross-hormone treatment and sex reassignment surgery to affirm gender identity in this population poses special considerations for the radiologist. Any surgical modifications are always a challenge for the radiologist to interpret. From a prosthesis to a mastectomy, there's always scar tissue and differences in the body habitus. And the use of hormones affects the physiology of the body. Remember, estrogen is a cell growth stimulator. So if you did have a cancer, it would not only stimulate the normal cells, but it would stimulate the cancerous cells to grow. As per the American Cancer Society, the estimated lifetime risk of males developing breast cancer is 1 in 833, while the average lifetime risk in females is 1 in 8. Just a personal caveat, in researching the American Cancer Society's literature, what we find is the table that they got the 1 in 8 for females is 1 in 8 females will get breast cancer in their lifetime if all females live past the age of 85. Also, this statistic refers to the risk of getting breast cancer and not the risk of dying from breast cancer. Today, there is a greater amount of patients that actually get breast cancer, male and female, that do not die from the breast cancer. We do know that the denser the breast, the higher the risk for breast cancer, and that we can categorize women into about 4 different types of fibrofatty breast tissues. Basically, the breast is made up of fibroglandular tissue, which is very close in atomic number, each of the components, and therefore very difficult to get contrast to be able to see a difference. The differences, or the greater differences in the breast tissue, will give us more contrast. Therefore, if we have a fatty breast opposed to a dense breast, we're going to get more contrast. Fat is easy for a mammogram to penetrate, so it'll appear see-through or translucent on the image. We not only worry about penetration for fat and fibroglandular tissue, we also look at things like nevuses or scars, and we need to mark those so that we know what they are on the mammographic image. Otherwise, the mole or nevus or the scar can mimic some sort of breast pathology. According to mammography supervisors, the top reasons for using skin markers are 1. To clarify and identify skin lesions and skin surface abnormalities. Skin markers also provide an accurate method of communication to the radiologist interpreting the images. The use of skin markers to mark the different areas on the skin will help to avoid repeat or unnecessary callbacks. More and more we're going from 2D mammography to 3D or tomosynthesis type of mammography. And the advantage of the tomosynthesis, of course, is a lot more detail because we're taking away the superimposition of the tissues. There is no doubt that digital breast tomosynthesis, or 3D mammography, has changed mammography. The clarity and the number of images helps radiologists see and examine more breast tissue in detail than ever before. Detection rates of early-stage invasive cancers are up, and patient recall rates are down. Communication tools such as mammography skin markers will help in the interpretation of digital breast tomosynthesis images. Transgender mammography requires the mammographer to be knowledgeable in the areas of positioning, exposure technique variables, anatomy and physiology of the transgender breast and its transition, and being able to communicate with transgender terminology and have the appropriate patient care skills. Lacking these skills can cause more repeats or callback exams. Statistically, for every 1,000 women who have a screening mammogram, approximately 100 will return for additional mammogram and ultrasound due to something seen on the initial mammogram. Out of those, 20 will find what was seen in the imaging is not likely cancer and return in 6 months to keep watch on the finding. Out of those, 5 out of the 1,000 will be diagnosed with breast cancer. 61 out of the 1,000 women having a screening exam will have additional imaging and find nothing is wrong. 19 out of the 1,000 will have minimally invasive needle biopsy required to find out what they're really looking at. In 2015, the American College of Radiology, the largest FDA-approved accreditation body, found that of all clinical images which were deficient for the first attempt at accreditation, 92% were deficient in positioning. So what about accredited ACR facilities? Also, in ACR accredited facilities, 79% of all unit accreditation failures in 2015 were due to positioning. The states of Iowa and Texas also accredit their mammography facilities. Similar results were noted by Iowa and Texas in 2015. Positioning was the cause of 91% of clinical image failures in Iowa and 100% of clinical imaging failures in Texas. We know that positioning is a challenge, and even more so with the transgender patient. So let's look at some examples of transgender mammograms. There is no reliable proof to guide the screening of transgender men who have had a mastectomy when the breast tissue is removed during a mastectomy. Women with a high BRCA correlation with risk for cancer often have a mastectomy to alleviate the risk of cancer. So again, if you're a transgender man who has had a mastectomy, you may not be able to look at a screening mammogram to get any idea about your breast, and may want to use ultrasound or MRI if there is any question about breast cancer. Diagnostic imaging using mammography, ultrasound, or MRI is the same in transgender and non-transgender women. Palpable abnormalities in the absence of free injected silicone can be evaluated with mammography and/or ultrasound. One of the problems with mammography is there is no consistency between one facility and another, and sometimes not even in the same facility between different mammographers. You need to have a standardized and uniform output to get comparable images. This means both in positioning and exposure techniques. Here we see the mammogram of a 25-year-old transgender woman who has been treated with hormone therapy, and her baseline mammogram shows unilateral nipple discharge. The 6-month follow-up shows increased retroareolar breast tissue. As we stated earlier, hormones can be a cell stimulator. This MLO and CC of a 50-year-old transgender woman treated with hormonal therapy for over 5 years shows a palpable mass in the upper outer left breast on the craniocaudal and medial lateral oblique mammographic views. This image is of a 43-year-old transgender woman treated with hormonal therapy for 10 years. Notice how dense the breast is. A 60-year-old transgender woman with free silicone injections feels a lump. Remember, we said silicone injections are illegal. The circled area shows you a mammogram of someone who's had silicone injections, like this patient. The palpable granuloma is designated by the blue and green arrows. Although admittedly a poor quality image, we see the area of concern here on an ultrasound. We also see a T1 MRI image labeled D, which is also not of great quality, but also shows that it is a non-enhancing area. After looking at D, we can see that on C, using an MRI T2 series called STIR, it lights right up. Here we see a transgender male after a mastectomy, and you can see the seroma or the swelling after the mastectomy on ultrasound. Here we see a picture of a female transgender patient who has been on hormonal therapy for 3 years. And notice she has a growth or like a fiber adenoma outside of the breast implants. Transgender men who have not had both breasts removed, a bilateral mastectomy, or who have only had breast reduction, should be screened for breast cancer based on the current guidelines for non-transgender women. Let's take a look at the transgender breast cancer screening guidelines for transgender men, which is female to male. If you did not have a mastectomy, you should be screened based on breast cancer screening guidelines for non-transgender women. If you only had a breast reduction, you should be screened based on the current breast cancer screening guidelines, again for non-transgender women. If you notice changes in the way your breasts look or feel, see your healthcare provider and ask about having a clinical breast exam. Now taking a look at transgender men, the mastectomy or breast removal and taking male hormones are generally protective and lower the chances of breast cancer in transgender men. While rare, there have been cases of breast cancer in men who had a mastectomy and received hormones. This is likely due to small amounts of breast tissue that remained after the surgery. Transgender men may be treated with testosterone for masculinization and elect surgery to create a male chest contour. Here we can see the masculinizing chest surgery with free dimple graft technique utilized. So you can see the placement of the actual surgery itself and the nipples, which will take time to heal. Here we see the masculizing chest surgery after 1 year. Transgender men who select surgical breast removal, which is referred to as top surgery, may have residual breast tissue if the surgical procedure consists of contouring of the chest and nipple sparing. Again, it's generally agreed that transgender male patients who undergo breast removal are at very low risk of developing breast cancer. Let's review the transgender breast cancer screening guidelines for transgender women or male to female transition. If you are 50 years of age or older and have had at least 5 years of hormonal therapy, you should have a screening mammogram every 2 years. While individuals undergoing male to female transition may be at a lower risk than cisgender or non-transgender females due to their lifetime estrogen exposure, we find that in estrogen therapy there is a concern that the high dose of the estrogen used for sex reassignment therapy may increase the risk of breast cancer for these patients because, again, estrogen is a cell growth stimulator. Remember, everybody is unique. Breast size and tissue composition following estrogen treatment varies for every person. According to the clinical practice guidelines for the Endocrine Society, development of breast tissue begins about 3 or 6 months following the onset of cross-sex hormone therapy, with the maximum growth expected after 2 to 3 years of therapy. After this time, most usually develop an A cup size from this therapy, although occasionally the breast can get larger. Transgender women who take high levels of estrogen develop breast tissue that appears radiographically similar to the tissue of cisgender or non-transgender women. This includes breast ducts, lobules, and achini, as well as the potential of developing cysts, fibroadenomas, pseudoangiomatosis, and stromal hyperplasia, and other benign findings. In addition, transgender women have a range of breast densities, and about 60% of these transgender women have dense or very dense breast tissue. Transgender women should consider mammograms after 50 years of age and after having taken hormones for 5 to 10 years. The chart at the upper left shows the effects and expected time course of feminizing hormones. Although there's not a large body of research about the risk of breast cancer in transgender women, the studies discussed suggest that this patient population is at a lower risk of breast cancer than cisgender women, but a higher risk than cisgender men. Transgender women taking hormone therapy are at a higher risk for breast cancer than males, but at a lower risk compared to females. An essential element of transition for transgender women is breast development. The transgender woman may be treated with estrogen for feminization, and in addition to estrogen, they can be given an anti-androgen, which will suppress hormones such as testosterone. The result is transgender women may have a greater chance of getting breast cancer due to the medicines they take to boost female hormones and lower male hormones. Since over half of the transgender women have dense breasts, screening mammography may be useful for finding breast cancer, but there may be other modalities required. Here we can take a look at the effects of estrogen on the skin, muscle mass, body fat, body hair, and breast growth. Estrogen can be administered in an injection, a patch, or a pill. Cross-sex hormone treatment for transgender women causes development of ductal epithelium and lobules, which vary in distribution and density between the individuals. The same breast pathology that occurs in natal women should be expected in transgender women. There are reports of benign entities such as fibroadenomas and lipomas, as well as malignancies, including a malignant phalloidesarcoma tumor due to the treatment with cross-hormone therapy. Let's take a look at the hormone replacement therapy in stages. And here we see pre-hormone therapy, and then 1 month, 9 months, 11 months, how the person looks at 12 months, 13 months, 15 months, and finally at 17 months. Approximately 60% of trans women seek breast augmentation surgery regardless of the type of estrogen used for feminization. As with cisgender patients, breast implants are imaged with standard oblique and craniocaudal views and using the Eklund displacement views. The biggest challenge for mammographers is when the patient has had illegal silicone injections or mineral oil or liquid paraffin or petroleum jelly to enlarge the breasts. These materials migrate in the fat and muscle, resulting in masses termed sclerosing or lipogranulomas, breast lumps, inflammation, pain, and physical disfiguration. Again, there is no difference in doing a transgender woman and a natal woman who has implants. You still need to displace the implant using the Eklund view or work around the implant, however, with your techniques and skill in positioning. Here we can see the application of the Eklund views where they displace the implant so as to better visualize the tissue of the breast. This graphic shows a demonstration of being able to use the Eklund method of displacing the implant. And we can see the corresponding mammograms, which shows the breast tissue with and without the implants. If you do get breast augmentation, you need to be able to plan for taking a week off to rest after the surgery, go for short, easy walks, wear a special bra for about 6 weeks, and avoid strenuous activity for the first few weeks after the surgery. Thanks for your time and attention, and we hope this brought a little bit of information.